Was it on? Oh, okay. Oh, so it's George Teitelbaum. If you want to use my middle initial, it's P as in Paul. The last name is spelled Teitelbaum, like the title of a book and bone.
Thank you.
All right. And then I'm the medical director of the Providence Neurovascular Center at Providence St. Joseph's Medical Center. No, Teitel.
What would you say is your patient care philosophy?
I think that it's important to.
I'm sorry. Just if you would repeat, my patient care philosophy is, or my philosophy when caring for patients is.
Mm-hmm.
You can start over, or you can just jump right in.
That's fine. Well, my patient care philosophy is always try to treat patients the way you feel that you would want your family members to be treated. And if it is not going to be something that's appropriate for yourself or your family member, don't do it. And in terms of how I would refer patients to another physician, it would be the same thing. Would I feel comfortable having my patient treated by this doctor or well, maybe you have to edit that. But if I feel uncomfortable having that doctor work on me or my family member, then I shouldn't be referring my patient to them. And I think that overall it's important to always show very conservative judgment when dealing with matters of the brain and spinal cord, because the consequences of your therapy can be quite dire. So you always have to consider, is this treatment really necessary, or is there a less invasive way we can do this? However, we are good at doing very aggressive, invasive things. However, I think that it's important to utilize those type of procedures only when your back is to the wall.
And how did you happen to choose neurointerventional surgery as your area of specialty?
Well, I got interested in interventional neuroradiology, also known as neurointerventional surgery, as a direct extension from my work in interventional radiology. I first trained in performing interventional or endovascular procedures in the body at George Washington University, and then was also on staff at Thomas Jefferson and Georgetown University, and finally ended up being the director of interventional radiology at USC. And the opportunity arose where I could train in neurointerventional radiology or neurointerventional surgery. And I thought that it was a great opportunity, and I took it. And after that, rejoined USC, but this time as a faculty member of the neurosurgery department.
How would you say your patients would describe you, Dr. Teitelbaum?
Let me think about that for a second. Well, I hope that my patients would think of me as being thoughtful and considerate and thinking about things in a very deliberate fashion and trying to keep them well-informed and always try to be transparent in my discussions and descriptions of procedures so they can always make an informed decision on their therapy.
And lastly, what would you say is the most rewarding thing about the work you do each day?
Well, one of the greatest rewards comes from successful procedures in children. One of the most rewarding things is a successful procedure in a child or a baby, and these I perform at Children's Hospital, Los Angeles. And other than that, it's when we can intervene with life-threatening conditions and save somebody without using a more invasive surgical approach. That, to me, is a very rewarding aspect of my job.
Anything you want to add?
Is there something that I missed?
You want me to do that last one again? Maybe it was too long, or
No, it was fine.
or maybe I'll do it once more for you. Okay.
Do you want me to ask the question again? Or
No, One of the most rewarding aspects of my job is when we can successfully treat children and babies, and this type of work I do at Children's Hospital, particularly if it's a life-threatening condition, such as a large short circuit between artery and vein inside the brain, and where there is no surgical option to treat children like these. It's also very rewarding in adults to achieve a successful result when trying to treat a life-threatening condition such as subarachnoid hemorrhage or an acute stroke, particularly when there is no surgical option for these type of conditions. And it's also equally rewarding to perfect new techniques that are innovative and maybe treat diseases that were less optimally treated in the past.
Anything else you want to talk about?
For neurointerventional side. Well, you know what I would humbly state is what makes me unique in the interventional community is that I offer the full range of services in both neurointerventional and also body interventional procedures. The body interventional procedures would include those that treat liver cancer as well as diseases such as HHT, also known as Osler-Weber-Rendu disease, and also liver conditions such as portal hypertension, in which a patient may have life-threatening bleeding or ascites, and we're able to treat them using the TIPS procedure. And there are also a variety of other body interventional procedures that we are expert in, such as the treatment of varicoceles, which is a leading cause of infertility, and also pelvic congestion syndrome, which is in women a leading cause of pelvic pain. So I'm very fortunate to have been trained in both areas and to be active in both areas and to provide some innovative treatments for a lot of very troubling conditions.
Excellent. Anything else that we should
have independent privileges apart from radiology departments that they allow me to go in to hospitals on the east side and also the west side. I'm at Children's here, Huntington, Glendale Adventist, and so and also Holy Cross. It's unusual to have somebody who can go to a variety of different places like that and still be part of the Providence family. So I don't know whether that's important to mention, but no, you got.
Okay, so yeah.
We were going to talk a little bit about.
There was a strategic plan of that. Well, what is also interesting about Providence bringing me on board is the strategic plan that we had in mind to link all of the Providence hospitals with regard to advanced neurointerventional care. Whether you know it or not, these procedures entail a tremendous investment, not only in materials, devices, and the like, but also in the training and the experience of people in the angio lab, in the intensive care unit. And it would probably be far more efficient to have one of the hospitals in the Kaiser system be the flagship institution offering these types of procedures. And still the window of opportunity for treatment is long enough so that you are able to treat patients who have had an acute stroke but who have failed intravenous tissue plasminogen activator therapy and still transfer them for more advanced stroke therapy, such as using the Mercy or Penumbra devices to pull or remove blood clots from the brain. And the same is true for patients who have suffered an intracranial hemorrhage from an aneurysm. It still would be possible to transfer them from the other institutions to the hospital that can provide the most advanced endovascular care for these conditions.
Why has the timeline been lengthened?
Well, the timeline for the treatment of acute stroke, as dictated by FDA guidelines for the use of these devices, is approximately 8 hours. Now, that may change. The philosophy of treatment may change, whereby we may attempt to treat these patients much sooner more like a heart attack, and to get them in sooner into the angio lab to treat them because time is brain, and we would like to try to preserve as much brain function as possible. So these things are sort of a moving target. The window of opportunity for treatment changes as we learn more about these diseases and how to treat them.